Yeah.
So very good evening to all of you, and thank you all for joining on this yet another Vertigo Grand Rounds. Today we have Dr. Nilotpal Datta. So Dr. Nilotpal Datta will be presenting. He'll be talking on pediatric vertigo. So he passed his undergraduation and post-graduation from Assam Medical College, Dibrugarh. And Dibrugarh is a very beautiful place, one of the first places to get oil in India, even during the British era. Okay, so that is, and it's a scenically beautiful place in Assam. If anybody gets a chance, you should not miss a chance to go to Dibrugarh. And from there, you can see the mountains of Arunachal from this side of Assam. And he pursued his fellowship training in neurotology from IAO, HNS, and ISO under Professor Anirban Bishwas, and was an associated consultant to him for several years.
No, I'm directly connected to the speaker.
And then he left
I'm not getting any audio input.
Okay. And he left to the United Kingdom for his DOHNS and MRCS ENT from RCPS Glasgow. While in the UK, he also completed a pediatric vestibular training course from Alderhay Hospital, Liverpool, under Professor Somit Dasgupta. And that explains the reason why he is with us today talking about pediatric vertigo. He is currently the consultant neurologist and in charge of vertigo and balance clinics at Medica Super Speciality Hospitals, Calcutta. In addition to Dr. Nilotpal, Dr. Nilotpal will be giving his experience, his approach to the pediatric pediatric vertigo patient, a simplified approach to the common causes from an ENT perspective. Following this, we will have Dr. Anusha Raj. Okay, Dr. Anusha Raj is a consultant pediatric neurologist and a developmental pediatrician at Mysore Child Neurology and Rehabilitation Center, Neuro Zone Gopal Gowda Shantaveri Memorial Group of Hospitals, Motherhood Hospital, Kangaroo Care Hospital, Suraksha Children's Hospital, Suyog Hospital, Sigma Hospital at Mysore, Karnataka. Okay, and when it comes to her experience, she finished her MD Pediatrics from Kasturba Medical College. Before that, her MBBS is from Mysore Medical College and Research Institute. Then she did the fellowship in Academy of General Education from Mahe in 2020. Then fellowship in Pediatric Neurology under RGHS in the Indira Gandhi Institute of Child Health. And she also has a fellow in postgraduate diploma in Developmental Neurology from Child Development Center at Trivandrum, Kerala University. She has multiple publications in a variety of field, in a variety of different kinds of diagnostic domains when it comes to neurology. Her entire, if I have to read her CV, like from her school days onwards, she's been a topper. She in the school days time she has won the district Young Scientist Award in the year 2008 from the in the event organized by the Department of Science and Technology, Government of Karnataka. And from there, throughout, from her MBBS days, PG days, and post-graduation days, and the specialization days, all the days she has been winning awards and prizes for her presentation, in addition to having number of publications. I welcome Dr. Anusha Raj to this evening. So
thank you, sir.
With that, thank you. So with that, I will request Dr. Nilotpal to take over the stage. And please, so this idea of the presentation today is going to be something like the first, Dr. Nilotpal, for the next half an hour, he's going to give you his perspective of the approach from an ENT's perspective, an approach to the pediatric patient with vertigo. Following this, Dr. Anusha will come and will share a few cases, okay, 2 or 3 cases with us, so that we get that perspective, okay, of how these people present and what are the differential diagnoses and how she makes a diagnosis. Okay, so with that introduction, may I request now Dr. Nilotpal to please come over and do his presentation. Yes, Dr. Nilotpal.
Okay, so I'll share the screen, sir.
Yes, sir, you can share the screen.
How to get it done? Sure. You able to see the screen, sir?
We are able to see, sir. We are able to see.
So you're able to see the presentation?
Yes, sir. We are able to see the presentation. You can start, sir. In fact, we are feeling vertiginous with the first slide. Okay.
So first of all, I'm audible?
Sir, I think you should start the presentation. We are seeing slide view. Okay.
Okay. So I'll just start. So thank you. First of all, I'd like to thank Srinivasa for inviting me for this grand round meeting. So the recent advancements in the several years in the diagnostic and therapeutic neurotology in adult population have made it very much simplified now to diagnose and to treat balance disorders in adult population. Even in the discrete interior parts of the country also, we are now easily being able to at least diagnose and treat these patients. But diagnosing and treating balance disorders in children is a paradox. Now, irrespective of age, balance disorders are diagnosed mainly on the basis of a detailed and accurate history, which we easily find it in adult population. But in children, this is rarely possible due to the child's poor communication abilities, narrowed vocabulary and distractibility, and more importantly, by a parent's distorted version of child's morbidity. Now, what happens is when a patient complains to you, adult patient, he will be able to tell that whether he is having a
Dr. Nilotpal,
Yes.
sir, I think
Yes.
your presentation slides are not moving. I mean, it is not. We are still seeing the slide view. Yeah, slide
Now
sorter.
it's coming.
No, we are still. It is moving, but the only thing is, we are seeing the entire thing rather than only the slide.
Present.
Yeah. Now it's perfect. Now it's perfect. Yes.
Okay.
Yes,
So now some of the salient features. So why it is difficult? It is because we don't get a perfect history, not the parents are also not sure what the child is actually having. Okay, so that becomes difficult. So therefore, treating a balance disorder in a child, it is not rare, but it becomes an enigma in case of a clinician for us. Now, some of the salient features of balance disorders in children is the balance disorders are not rare in children. The incidence is 0.7 to 15%. Now, one of the very common causes of vertigo in children are ocular causes, that is conversion anomalies and latent strabismus. Now, this is very important to focus here because in adult population we are not so much addicted to the televisions, but in children what happens, regular use of our television and nearby their laptops or iPads, they are having a frequent movement of the eyeball, and that causes a latent strabismus and conversion anomalies. Now strabismus is something where the eyes do not focus on the object. When they are particularly seeing an object, there is a movement or disequilibrium of the eyeball. So that causes a vertiginous sensation. Now, the other causes are some of the central causes, which Madam will also focus in the later on our presentation, will be basically the space occupying lesions and other causes like meningitis, multiple sclerosis, and other central causes of disorders. These are much common. Now, when a child comes to you with a balance disorder of vertigo, so in adults, we don't always get a space occupying lesion or posterior cerebellum stroke or all these things. But in child, when he comes to us with severe vomiting, all these things, then we should keep this in mind to at least go for a CT or MRI if you are having some suspected central signs, because it's commoner as compared to the adult. Now, coming on to the commonest cause in pediatric population is the benign paroxysmal vertigo of childhood, which is basically a migraine variant, and it's basically a migraine plus a somatoform disorder. It is basically a bit different from a migraine. It's a variant of migraine, but it is not a typical migraine. It's a combination of some of the migraine features and a somatoform disorder. So I will go into the details and how to differentiate it from typical migraine in the subsequent slides. Now, this is the epidemiology of pediatric vertigo. Is basically we have to find out whether what is the prevalence, what are the causes it can be. So it will last from around 0.7 to 15%. Now, this is the causes are benign paroxysmal vertigo of childhood. Now, migraine associated vertigo, ocular abnormalities, head trauma. This is a commoner thing as compared to the adult population. Now, childs are going to school, they play around, they tend to fall, and sometimes due to fear of being scolded, they don't often come to their parents and tell that they have got a head injury. But there is a concussion vertigo as another specific item, the specific entity that is very much common in children population. Is there is a labyrinthine concussion which ultimately leads to a sense of disequilibrium in children. Other causes are vestibular neuritis and others, some non-specified cause like nutrition deficiency, etc. Now, for adult population, now when an adult patient comes to you, again, you can find out what are the presenting symptoms. It can be vertigo, you will tell it's syncope, or is having some headaches, you can tell you. But how would you know a child is having a balance disorders? Now, these are the few of the presenting symptoms which you should keep in mind when seeing a pediatric case in your clinic. They will be having irregular writing styles, now clumsiness of the movement and poor posture, reading or skipping words or letters, irregular writing style, visual acuity problems, especially when in movement, they will be having some kind of movement problem. They will see that they will unable to tell you in their language, but you have to see it properly. And the parents also sometimes can find out that their gait, there is some problem with the gait. Difficulty walking in darkness and delayed motor development. So if a patient is coming to you with a delayed motor development, so asking the developmental milestones, basic things is very important. Now, in a nutshell, the most important presentation which I have found in some of my patients, I have recently started this pediatric vertigo clinic in my hospital, so I'm also very new to this subject, but the most common presentation which the parents comes to us is a very typical thing, like a child is playing around in the room and suddenly he feels that he suddenly clutches his caretakers or our parents and says there's something is going to happen, as earthquake has come or something around. Everyone is shocked. After a period of 4 minutes or 5 minutes, few minutes, he's again completely normal. This happens infrequently, sometimes in a period of 1 or 2 days, 1 or 2 episodes in a day. So if your child coming to you, if your parents presents it, then you have to suspect that there is some kind of problem with the balance system. It could be either in the peripheral part or in the central part, that we have to subsequently evaluate. Now, this is some of the developmental milestones which we all have studied during our pediatric MBBS days. I'm not going into details of it, but these things you have to keep in your clinic for reference. And you have to go through it, because remembering all these things may not be possible in a busy ENT clinic or when you are getting more of adult cases, but this can be taken into references, because this is a very common thing when motor milestones are there. Now, coming on to etiology of vertigo in children, some of the causes like central, peripheral, genetic, and others. Like central cause, there are some causes like migraine, or it could be space occupying lesion, meningitis, or some kind of Earldon cherry or multiple sclerosis. And in peripheral things, we'll have disorders like vestibular neuritis or otitis media effusion, sometimes labyrinthine injury. And genetic causes, which I will tell you in the subsequent slides, are also very common in case of some of the population. Now, these are some of the central causes like migraine-related vertigo, benign paroxysmal vertigo of childhood, epilepsy or seizures, which are much more commoner in children as compared to the adult population, post-meningitis, multiple sclerosis, tumors of CNS, central nervous system. It could be medulloblastoma, rhabdomyosarcoma. All these tumors are there. Somatiform disorders, very common, mainly in the adolescent females. And sometimes hydrocephalus also can present with central causes of balance disorders in children. Now, coming on to the peripheral causes, it is quite similar to the adult ones, but otitis media effusion, as we all know, is much more commoner into the children due to a very narrow and small eustachian tube and recurrent URTI. So OME-related dizziness is very common due to the toxic chemicals released during that otitis media effusion stages. Then viral labyrinthitis, vestibular neuritis, perilymphatic fistula, again can be due to any concussion injury of the inner ear, which is much more commoner due to recurrent falls in the children. Meniere's disease is also present in some kind of patients. Positional vertigo, they have given it in the literature but from my experience, I have not till now got any patients of positional vertigo in patients. And bilateral vestibulopathy in some patients with ototoxicity or some genetic causes can be there. Now, these are some of the causes of genetic syndromes like the Pendret syndrome, the Usher syndrome, enlarged vestibular aqueduct syndrome, Joubert syndrome. Now, in Pendret syndrome, we basically have goiter. There will be a goiter, and it will be due to a genetic defect of SLC26A4. And it is basically a goiter with deafness. If a patient is coming with thyroid swelling with a deafness, there is a strong index of suspicion of Pendret syndrome. Other abnormalities which can be there is Mondini dysplasia due to mutation of the PDS gene. Now, in case of Usher syndromes, there are two subtypes which are common with the balance disorders, Usher subtypes 1 and 3. And for Joubert syndrome, it is basically a genetic cerebellar disorder and Skibbe dysformity where there is a dysplasia of cochlea and saccule. But the utricle and the semicircular canals are usually, these are normal. Now, coming on to some of the other causes are like orthostatic hypotension, few drugs, octotoxic drugs, trauma. Again, I told you about the labyrinthine concussion injuries, which are very common in the children, and the ophthalmological causes, as I already mentioned, like conversion abnormalities and strabismus with binocular occlusion. And these are very common in pediatric population. Now, the most common ones, which we might regularly get into our vertigo, pediatric vertigo clinic, is migraine variant vertigo. That most commonly is benign paroxysmal vertigo of childhood. Acute labyrinthitis or neuritis, somatiform vertigo, very common. It is also form of conversion disorder, which are very commonly seen in adolescent females, basically due to some of the emotional setbacks. I recently have a patient around a couple of weeks back who is coming to us telling that he's having a vertigo, all this thing, all MRI is done, all ECG is done the vestibular function test, everything is normal. Her age was around 16 odd years. But when I asked the child in detail, and I in detail alone, I took the child and had an attendant around him. Then I came to know that he was having some kind of physical torture by some of his parents and his other relatives also. That is causing an emotional setback, and that is causing a conversion disorder in him. So that psychological impact, like we see in adult population, we have a anxiety depression score or dizziness handicapped index, which we all measure or we should measure in our vertigo clinic. So in pediatric population also, having a clinical psychologist in your clinic, or at least going to the basic psychological problems or any kind of psychiatric disorders, can also have to be questioned in a patient of pediatric vertigo. Other causes are labyrinthine concussion and Meniere's disease. Now, these are some of the basic clinical tests which are required in a child with balance disorders. Are the basic cranial nerve examinations. You don't require so much sophisticated some instruments for running a pediatric vertigo clinic. Is the basic neurological examination, which we all do, all the oculomotor tests as much as possible. It is impossible to do it in a very small child, but a child above the age of 6 years or 7 years, you can have some chocolates or some toys, which I do, and we can give the patient all that, and then you can at least ask the patient relatives to all parents to also help them cooperate with the child. So you can do these basic neurological examinations with neck movement, and all these vestibular ocular tests like the spontaneous nystagmus can easily be seen, and oculomotor test, gaze nystagmus, head impulse, and head shaking test. I usually don't do much of positional test in children, and then the basic standing and stepping tests. So these are the basic clinical tests which you can be done in a clinic. Now, what are the investigations which are important in a pediatric vertigo clinic? Is complete eye checkup, especially the convergence test like the strabismus and refractive errors. Now, when you are sending a patient for an ophthalmological evaluation, Now, whenever you are coming, means as ophthalmological causes are quite common causes of vertigo in children, always try to mention these 2-3 things to the ophthalmologist so that it becomes easier for your colleague ophthalmologist to find out. So always when you are suspecting a balance disorder in a child, so you should always go for special tests like Virgin test and strabismus and refractive errors to be ruled out in these children when you are referring these patients. Normal audiological tests like tympanometry to rule out any otitis media effusion, which usually may lead to sometimes a cause of imbalance in children. Now, MRI of the brain, as I already told you, to rule out some of the space occupying lesions, structural defects like Chiari malformations, multiple sclerosis, encephalitis, and congenital cholesteatoma can also be ruled out by MRI. Now, vestibular function test, I usually don't go for all this battery of tests because it becomes irritable for the child also. So basic tests to find out is the do a VOG and a DVA to find out is there is any behavior abnormality in the child, and sometimes a subjective visual vertical, which the child becomes very fascinated to play it like a video game. So both the DVA and SVV can be easily done in a children, and the VNG for the basic to rule out the basic oculomotor examinations along with the spontaneous nystagmus. And very important, as I already told you in the previous slide, is psychometric test. If you are finding out that there is a remote possibility of any psychological overlay in this child, then you can send your child for to your psychological counselor colleague in your hospital to rule out if there is any kind of anxiety, depression, or other psychiatric abnormalities in these children. Now, what are the neurological deficits to be looked for in a child so that we can refer it to a pediatric neurologist in your hospital? Is hypotonia, tonicity or spasticity of the limbs, exceptional sway on the walking test with eyes closed, difficulty in doing the fine motor skills, like if you try to write, tell the patient to write, they won't be able to write, they will be writing irregularly, like the Fukuda's test we used to do earlier for finding that in case of cerebellar disorders. This can be easily done in a child if you can try to tell him to draw some articles in a white page. Now, any intention tremor or torticollis of the movements can also suspect a central cause of balance disorder in children. Any congenital nystagmus to be looked for. Now, radiological investigations which we should do is try to rule out any enlarged vestibular aqueduct, any Chiari malformations, anomaly of the middle and inner ear like congenital cholesteatoma, Mondini dysplasia when there is a 1.5 turns of cochlea, Pendret syndrome, as I already told you, where there will be deafness, and thyroid abnormalities where there will be inculcated Mondini's dysplasia, and Squibb dysplasia where there is congenital absence of the vestibula and some of the cochlear structures. Now, fracture lines in the temporal bone, very important when there can be a subclinical fracture. And if you are suspecting something that the child is having a trauma history or is an aggressive child who has history of falls, then you should also do a CT of a fracture temporal bones. Now, cerebellum and brainstem disorders, some space occupying lesions like medulloblastoma, astrocytoma, meningioma, and epidermal cysts has to be ruled out. If you are suspecting some causes which may lead to a balance disorder, central causes that may lead to a balance disorder in children. Any signs of demyelination like imbalance, vomiting, severe headaches if he is complaining of, and any hydrocephalus if you are suspecting, then you can ask your radiology colleagues to have a look into it and advise an MRI of that. Now, benign paroxysmal vertigo of childhood. Now, getting into a bit detail of one of the most commonest cause of vertigo in childhood. It is an International Headache Society approved as a part of periodic syndromes of childhood, which are precursors of migraine, but not typical migraine that I already told you. So what are the differentiating points and how will you differentiate that it's a pure isolated migrainous vertigo or it's a benign paroxysmal vertigo of childhood? These attacks are paroxysmal, non-epileptic, recurrent, event characterized by subjective or objective vertigo without any additional neurological problems. Usually they will be having recurrent episodes of this giddiness and vertigo. And if the child is a bit elder and if he has got a good vocabulary and understanding skills, he or she will definitely tell you that I don't have any kind of intolerance to light or any other abnormalities during the spells of vertiginous sensations, and it will be only isolated vertigo. Then there will be normal EEG and no detectable neurological deficits. Even your neurology colleagues will also be not been able to find any specific cause relating to the vertiginous spells. Now, in between the attacks, there will be normal audiological and vestibular findings. So there will be all the audiovestibular function tests will be normal. So these will be recurrent sudden brief spells of head spinning, usually rotatory sensation, rarely lasting for few minutes. Several attacks during a day to even a month can occur. Child conscious but frightened during attacks and often clutches as adults, but after the attacks becomes perfectly normal. That I already told you, sudden clutching of the caretakers, like something earthquake has come up, but again becomes normal and starts playing normally. So if your parents specifically complain this, always keep in mind it could be BPPOZ. What are the accompanying features? Sometimes due to fear, excessive anxiety, there may be pallor. Sometimes in the irritative stage, you may get nystagmus. Now, finding this is another problem in a running a balance disorder a pediatric clinic, that there's a rapid compensation in case of pediatric spasticity of the brain. So when a patient comes, pediatric patient, even if it's having an acute stage, it will fastly compensate because it's fast compensatory mechanism of the brain. And till the time he or she comes to your clinic, rarely you'll be getting any acute nystagmus or acute vestibular symptoms. So it will be basically on the clinical examination and whatever history you can gather from the parents, that will be always guiding you to the diagnosis. Now, attacks are basically unprovoked, not associated with any head movement, no trigger factors. Now, in migraine, there will be trigger factors, like there will be headaches, some family history of migraine, the patient will have motion sickness, or when he is hungry, the patient will tell he's having these dizzy attacks. But in case of a benign paroxysmal vertigo of childhood, there will be no trigger factors. It will be unprovoked. And age of onset will be 0 to 4 years, but often in 5 to 10 years also we can see these patients. Now, usually these are true spinning, rotatory sensation, but often maybe just brief phases of imbalance, lightheadedness, and movement associated disequilibrium. Now, these are diagnosed based on typical clinical picture only. Usually the radiological, audiological, vestibulometric test, ECG, everything is normal. Prognosis is good, usually subsides with the period of 10 to 12 years. And diagnostic criteria are basically typical history, family history of migraine to differentiate it from the typical isolated migraine vertigo, and any history of motion sickness has to be ruled out. Now, diagnostic criteria for migraine-related vertigo in childhood, these are recurrent attacks of vertigo and imbalance, migraine headaches according to IHS criteria, at least one of the episodes of giddiness is having nausea, vomiting, photophobia, phonophobia. So this is common in migraine-related vertigo in childhood, but you won't be getting these signs and symptoms if it's a benign paroxysmal vertigo of childhood. Now, trigger factors present like stress, lack of sleep, excitement, physical strain, hunger, exposure to sunlight, traveling in car, all this will be the triggering factors if it's a migraine-associated vertigo. Now, in children, migraine and somatiform disorders often are found together and contribute substantially for pathogenesis of the balance disorder. So this comprises of majority of the population coming to you with balance disorders. Now, how to differentiate it? Now, if it's a migraine related vertigo, it is basically you will be having all the typical features of migraine and all this photophobia, phonophobia, all this thing, and there will be a less somatiform vertigo, less anxiety induced symptoms in those patients. Now, if it's a migraine somatiform vertigo, then there will be a migraine comorbidity with it, along with some psychological effects also with the pain. Basically, there is in adult neuropathology journals, you'll be finding a new term which has come out, is migraine anxiety related disorder, that is MARD, where you change the course of the drugs. Why this is important? In all these things are important to which drugs to use. Now, if it's a migraine related vertigo, you cannot use some antidepressants like venlafaxine or SNRIs. You should not use, because it will induce another depression. Now, if it's a migraine somatic vertigo, you already have an anxiety depression comorbidity in those patients. So in these patients, you have to use a drug which is having a migraine property along with a psychomotic property. Like you can use amitriptyline, works well in these patients along with the SNRIs like venlafaxine or dense venlafaxine. But a flunarizine again will induce a depression in a child. So if it's having a migraine somatic form vertigo, again you are giving flunarizine, so it will again induce the symptoms will trigger more, and you will not be feeling well as when giving the medication. So this is very important to differentiate what actually the entity is. So the prescription of your drug becomes easier. Now, this is some of the international studies which have been done, the commonest causes of migraine vertigo and migraine somatic vertigo and somatic vertigo. So in all the age groups, only in case of girls, we have seen that it is basically the migraine somatic vertigo which has have a higher predominance as compared to the boys. Now, this is another study which shows that isolated migraine-related vertigo and migraine-related somatic form vertigo are the majority causes of vertigo in childhood as compared to the other smaller causes, lesser known causes like peripheral vertigo or isolated somatic form vertigo or vestibular post-traumatic vertigo or orthostatic regulation. Now, in my pilot study, it's a very small study. I've just got around 25 or 26 odd patients in the last several months, which I have started my practice. Usually the mostly diagnosed case in my part is around 12 patients were from benign paroxysmal vertigo of childhood, and migraine patients were around 7, which have all this history of migraine and family history and everything. Purely 4 or 5 patients, I have 3 or 4 patients I have found who are purely psychomotic and were explaining themselves as getting recurrent attacks of vertigo, but basically were a psychosomatic patients. And in 2 patients, these were nutrition deficiency unspecified causes. Now, vertigo in OME is a commoner cause in peripheral vertigo. Now, what are the pathophysiology is pressure changes in the middle ear, and sometimes there is a serous labyrinthitis going on, which causes a bit of disequilibrium in children. And this is same as management we do for a hearing loss in OME, like medical management and grommets. Ocular disorders, I already told you, like convergent insufficiency, latent strabismus with binocular vision, refraction errors, and defect in binocular vision, usually find in children around 6 to 10 years. And VNG for oculomotor tends very, very essential in children with vertigo. Whatever things you do, go for an MRI, go for an eye checkup with an ophthalmologist, do a basic VNG if you are not affording the DVA and SVV and other tests. CNS cause, I'm not going into that, but very important of MRI and EEG must for any child presenting to you with vertigo and balance disorders in clinic. Clinical features of an enlarged vestibular aqueduct, usually severe sensorineural deafness the patient will have, sometimes fluctuating combined with episodic vertigo. If a patient is having severe deafness along with spells of vertigo, you can suspect and go for an CT or MRI. And these are some of the causes which I've already mentioned. Postural imbalance in children without hearing loss, congenital bilateral vestibular failure I have not encountered any patient till now, but these are there in the literature. Infratemporal tumors like vestibular cerebellum, pontomedullary brainstem structures, Arnold-Chiari malformations, these will present only with balance disorders, no hearing loss. And if with hearing loss, there could be rare genetic inherited disorders. Very important part of our discussion today is how to treat it. That is very important. Diagnosis, okay, we have done it. How to treat it? For acute vertigo, this is my protocol, whatever I have learned in these several years of practice. Acute vertigo, below 2 years of age, only use antiemetics. I personally prefer Phenergan. Depending upon weight, you can age very small, it's 2.5 ml to 5 ml, whatever is, you can use it. 2 years to 6 years, I always go for dimenhydrinate, 25 to 50 mg, even 12.5 also if the patient is much more drowsy. Because dimenhydrinate doesn't have much anticholinergic or antidopaminergic activity. Above the age of 6 years, I go for meclizine, 12.5 milligram, and even you can go for dimenhydrinate. Above the age of 12 years, I go for meclizine 25 mg. Never ever use a drug chlorperazine in a child with vertigo. Severe anticholinergic and antidopaminergic effects. So as your child's brain is not much developed as compared to the adult population, then the chances of side effects and adverse effects of this extrapyramidal symptoms can be more in a child. So try to avoid prochlorperazine in a child. Now, if it's a recurrent vertigo, what prophylactic medicines I prefer to use and what's there in the literature is basically flunarizine, amitriptyline, topiramide in case of some of the refractory case, 1 to 4 milligram per kg in divided doses. Propranolol works well if it's a panic attack kind of a thing, is having hyperexcitability or some kind of intention tremors. So you can use propranolol, but try to avoid it if he or she is having asthma, it's caused of vasoconstriction. And motion sickness, if the child is presenting with motion sickness, good drugs which I have found very good results are sinerzine, cyproheptadine, 2 milligram BID for 2 to 6 years. And if it's above the 6 years, you can go for 4 milligram thrice daily. And in case of somatic disorders, we can go for benzodiazepines and SNRIs. So to end, what's the take-home message for today? Incidence of vertigo in childhood is variable, not as rare as perceived. Migraine and migraine-related disorders are the commonest cause, and adult causes uncommon but possible. Ophthalmological causes and CNS more commoner in children as compared to the male. And thorough clinical examination with a thorough detailed history with your parents and investigations. Most importantly, VNG and audiological test and MRI of the brain and the ophthalmological test can help you to get some idea about the balance disorders in a child. So before ending the presentation, I would like to thank from my gurus from whom I have learned this art of neurootology, starting from the basics of neurootology, Professor Biswas, who has been instrumental in bringing me to whatever I am doing here today, and Professor Dasgupta sir, excellent pediatric neurootologist, to bring who have helped me bringing this interest of pediatric vertigo. I'm very new to the subject and would love to hear from all of the participants today, if you all can have much more inputs regarding this topic. Thank you very much.
Dr. Nilotpal, you are telling very new, but you are giving very beautiful points. Okay, and they were very nice from the starting, from the way you stressed on the ophthalmological problems onwards, to giving us the perspective in different age groups, in boys versus girls, the not just the central peripheral, some of the inherited conditions that you spoke about, and also the golden slide about what drugs to give and what drug to avoid. Really very nice insights. Thank you so much. Thank you so much, Dr. Nilotpal. I'm sure a lot of questions will be there. So, but before we go to the questions, I would first want Dr. Anusha to come in.
Yeah.
And yeah. And ma'am, you can present. I think
I'll
you have
start
a few cases
sharing.
to yes, ma'am, you
I'll
can
share
please.
my screen.
And post which we'll take questions from the
Sure, sir.
delegate. Thank you.
Is my screen visible?
Yes, ma'am, it is visible.
So, hello everybody, I'm Dr. Anusha Rajke. I'm a consultant pediatric neurologist at Mysore. Firstly, I would like to thank Cyclops MedTech and Srinivas sir for giving me this opportunity to share my experience in dealing with pediatric balance disorders. So, Dr. Nilotpal sir has definitely shared an amazing overview on all the balance disorders seen in pediatric age group. So I would just like to pinpoint 3 interesting cases which I recently saw in my practice. So case 1, here we saw a case, child is 10-year-old girl with normal birth and development. She came with presentation of episodic unsteadiness. Unsteadiness was lasting for few seconds and it was associated with impaired consciousness. During the episode, child had open eyes, staring light when exposed, and these episodes were triggered when exposed to bright light. And these episodes were noted multiple times since the last 2 months. So on exam, we did a neurological examination. There was no deficits, there was no nystagmus or no other cerebellar signs. And ENT otological examination was done. No vestibular signs were positive. So basically, here the child has unsteadiness, so which can be described as dizziness also. But child had something like an paroxysmal event, which is open eyes and staring, and child was having impaired consciousness. So firstly, when there is an impaired consciousness and staring like episode, which is paroxysmal, we need to suspect, although the primary complaint was dizziness and unsteadiness, also we need to keep in mind there is a possibility of an epileptic event. So along with the neurological and otological examination, we did an EEG test. And when we did an EEG test, it was abnormal with sharps and spike discharges from the parieto-temporal region. And MRI brain, when done in this child, it was normal. So this is the EEG pictures. You can see there are discharges in the parietal, bilateral parietal, P3 and T5 from the left side, and which was having some kind of generalization. So moving forward. So with this history and the investigation findings, we came to a diagnosis of epileptic vertigo. And this child, we start because there was a temporoparietal disturbance. Temporal lesions in a child predominantly responds very well to carbamazepine and oxcarbamazepine. So we started the child on oxcarbamazepine specifically because it has less side effects as compared to the carbamazepine. And child has been asymptomatic since the last 2 months. So let us know a bit about vestibular epilepsy or epileptic vertigo and nystagmus. It's a rare cause of vertigo. Here we find lesions in the temporoparietal junction or the insular cortex, specific EEG abnormalities with epileptic discharges from these regions we see. MRI, if the lesion is significant, you can pick it up. Otherwise, you may have to require a 3 Tesla MRI. Usually 1.5 Tesla MRI will not pick up. Just because the MRI is normal, you should not think that there is no abnormality. We need to consider the history and the EEG findings as significant, and we'll have to treat these cases accordingly. Such cases, as I've seen, they show very good response to carbamazepine. And moving forward, second case is a 12-year-old boy with normal birth and development. He came with history of recurrent history of sudden falls while standing or walking since the last 2 weeks. And this was associated with blurred vision and giddiness. And according to the mother, child was partially impaired responsive during these episodes. But when I probed further, there was no history of loss of consciousness. It was not associated with any nausea, vomiting, or headache. And post-episode, child did not have any drowsiness or post-ictal state. Neurological examination in this child, actually, when I first examined this child in my clinic, so there was some kind of an imbalance and ataxia kind of features. But all the cerebellar signs were not consistent. So further, I thought we should evaluate further. I took an ENT opinion and otological examination was done. Head impulse test was negative. And so in this case, we were suspecting, okay, child may have had, it could be like a vertigo, or it could be like a syncope, or it could be an epilepsy. So we evaluated this child further. We did an EEG, echo, and an MRI brain, all of which was normal. So the interesting thing in this case, when they came to show the report on the next day, I re-examined the child, and completely, I could not see any neurological deficits or any cerebellar signs, which was noted previously. So there was complete inconsistency in my examination findings in 2 different settings. So then I probed further for stressors. Child had a lot of stressors related to school, academics, and child had an increased screen time. There was a recent change in school and city with the family underwent. There was a lot of adjustment issues and family environment issues. So with this, I was able to make a diagnosis of somatoform functional neurological disorder. So after which I counseled the patient regarding the condition. And what I advise them is a lifestyle modification to avoid the stressors. And they had underwent a counseling with a child psychologist and behavior therapy. And now the very interesting thing is child is completely asymptomatic and fine since last 2 months, and they're under follow-up with me. So let us know a bit about functional and psychiatric causes of dizziness. It's most common, as Nilotpal sir has said, most commonly seen in adolescents. So what happens? They may have an episodic psychiatric disorder or exacerbation in any of the chronic psychiatric or functional disorders like PPPD or generalized anxiety, these exacerbations or episodic disorders may cause both vestibular symptoms in the child. The cleanse to the diagnosis is a very careful history taking, and you may have to take history repeatedly, just as in the previous case, where in the first time I was not able to get a clear-cut diagnosis. On repeated evaluation, the diagnosis was more clear. And we need to evaluate for the triggers and stressors and specifically target them so that the child will become better. And the main treatment for this child is CBT therapy, biofeedback therapy, and SSRIs and SNRIs if the symptoms are very severe. I would like to briefly tell regarding the persistent postural perceptual dizziness, PPPD. So it's a functional neurological disorder associated with non-vertiginous dizziness, and there is a sense of imbalance which is exacerbated in a certain positions like standing, turning, or a constant visual flow. It can be precipitated by any event which can initiate a dizziness or vertigo imbalance in the child. So these patients always have the fear of falling, and the cleanse to the diagnosis will be, it is not just the isolated episodic imbalance which this child have. Baseline on a daily level, there is a low level of dizziness, which they clearly tell in the history. And whenever there's a trigger, there are constant frequent flares seen. And most commonly, it's worsened in the large open spaces or whenever there's a high flow visual media settings, as in a movie theater or in malls. And they have a good response to escitalopram and fluoxetine. So moving to the third case and my final case. So this is a very interesting case, which I saw during my training period in Indira Gandhi Institute of Child Health. So we had an 8-month-old girl with normal birth and development. So this child was brought with history of recurrent episodes of head tilt, sometimes towards the left, sometimes towards the right, lasting for 5 to 10 minutes. And sometimes these head tilt episodes were associated with vomiting, but it was not associated with unresponsiveness during these episodes. There was a family history of migraine in the mother. The neurological examination and the development of the child was normal. The eye examination was normal. Initially, when we saw this, we suspected it to be an epileptic event. So then we did an EEG test, which was normal, and MRI brain, which was normal. So this is the video. I'll just play. You can see the child is looking towards one side. Then eventually you will see the child will have a head tilt. See, the mother is trying to feed the child during this episode. Child is accepting the feed. That means there is no impaired awareness. And the child suddenly will turn the head towards one side and keep in this posture for a few minutes. So these episodes were noted recurrently. But very clearly you can see there is no impaired awareness. Child is aware that the mother is trying to feed and child is accepting the feed also. There's no regurgitation. But the child is trying to keep the head in a certain comfortable position, which is like the left lateral position. Child is tilting the head like this again. So these episodes were seen recurrent multiple times, and it was not just towards the left side. Sometimes it was towards the right side. And so you can clearly see here the child is taking the feed. It's aware. There is no ictal activity going on. The child is just trying to comfort itself, keeping the head in a certain position. So moving forward, so when we see such a type of a paroxysmal event, what do we think? So the differential diagnosis in such cases would be, very commonly what we see in infants is a GERD, gastroesophageal reflux. When there is a reflux, children, babies, infants especially, try to keep their body and head in a certain positions. Then the next thing, focal seizures with or without impaired awareness. As I had told before, that was what we primarily thought. then there can be a torsional dystonia, like hereditary DYT gene defects. But in this case, the dystonia, here you can see it is only cervical, specifically cervical. There is no other kind of dystonia involving the other parts of the body, and the family history of any dystonia is not there. And then other differential would be acute dystonia due to medications like neuroleptics, like haloperidol. When they're giving to the child, you should take a drug treatment history also in the child. And if there is a congenital muscular torticollis, so it will be present from the birth, and it is non-paroxysmal. In this case, the events are very paroxysmal and occurring at a specific times and frequencies. But the congenital muscular torticollis will be non-paroxysmal torticollis, and you unilateral, you can find a stiff palpable sternocleidomastoid. And when there is a, you should also suspect the lesions in the posterior fossa or cervicovertebral junction. This can be ruled out. There will be other neurological features, and your MRI will help you cleanse the diagnosis. And as sir told, we can ocular misalignment and ocular motility disorders can also make the child go into torticollis position. And the last but not the least, what we diagnosed in the child was benign paroxysmal torticollis of infancy. This is the diagnosis of exclusion. So let us know more about benign paroxysmal torticollis of infancy. These are the recurrent episodes of head tilt seen secondary to the cervical dystonia. It is often accompanied by vomiting, pallor, irritability, and malaise. And these episodes can last for hours to days, and they can be associated with tortipelvis and retropelvis. And they usually have a family history of migraine, and some of the genes associated with the familial hemiplegic migraine, like CACNA1A, PERRT2, ATP1A2 genes, which are known to cause familial hemiplegic migraine, are also known to be associated with this. And the pathophysiology is not very clear, but what is attributed is a vestibular dysfunction or vascular disturbance in the brainstem. This disorder usually starts within the first year of life, and it's self-limiting and resolves by 5 years. But eventually, post 5 years, these children can evolve into paroxysmal vertigo of childhood and vestibular migraine or typical migraines. Basically, this is the diagnosis of exclusion. We need to rule out all the other causes which I mentioned before. And coming to the treatment, the child does not require any treatment. There is no drug of choice. Basically, change of position and can be tried, and we need to counsel the parents regarding the condition. There is articles telling the medications like analgesic like acetaminophen, ibuprofen, ondansetron, diphenhydramine have been tried, but there is no clinical basis. This condition is completely self-limiting and does not require any treatment. So the early signs of vestibular functions, what we see is low muscle tone, delayed primitive reflex, delayed gross motor milestones, developmental delays, seizures, nystagmus, easy fatigability, and torticollis. These are the very early signs in a child with poor vestibular function. If you pick these signs, you need to evaluate further. And what is the difference between children and adults in a vertigo? Children, the main thing what I found in my experience is the children will have more difficulty to describe the symptoms, like to differentiate between dizziness, vertigo, head spinning, and the impaired consciousness. It's very difficult as the history is not very clear. And to appreciate the nystagmus in a child also can be difficult, because sometimes they'll not evaluate the ocular movements, because the cooperation of the child will be difficult. And children are more likely to have vertigos related to migraines than vertigos related to a Meniere's or a vascular etiology. Most commonly seen causes, as sir has told, is benign paroxysmal vertigo of childhood and vestibular migraine. Similar to my clinical practice, these are the most common causes seen in the childhood. And these are some of the assessment tools which we can use in children. Vanderbilt Dizziness Handicap Inventory for patient caregivers. We can use it in the age group of 5 to 12 years. From the caregiver's perspective, you can assess it. And then pediatric vestibular symptom questionnaire. It helps us to discriminate the vestibular pathology in the children with almost 95% sensitivity. These are my references, and thank you so much. Thank you, Cyclops, and thank you, Srinivas sir, and thank you, Nilotpal sir, for this wonderful opportunity.
Thank you very much, ma'am, for sharing those wonderful insights, especially with the patient reports. I have a very quick, very fast question that I want to know. Like you told about some genetic afflictions causing. Now, if you have to send these children for genetic testing, how do we do it, and which lab does it, and how do we order for the genetic testing?
Okay. So basically, sir, to detect these genes, we need to do a whole exome testing. So whole exome testing is initial. Previously, if you say 5 to 10 years back, the cost was around 40 to 50,000. Nowadays, there are many labs which offer this test in the cost range between 12,000 to 20,000. There is Newberg, there is LifeCell, there is MedGenome, Biome. These are the few of the companies which I regularly interact with, and their cost range is between 12,000 to 18,000 for a
So
whole exome testing.
this is called whole exome test.
Yes, whole exome genetic test. Yes.
So in the sense, like for example, if these migraine related genes that are there, they will pick up and they'll tell it for us.
Yes, yes.
If there are
yes, sir.
if there are episodic ataxias, they will tell on its own.
Yes, sir. So if we give them the clinical crux of the clinical history, then they'll target those specific genes, and we'll be able to pick it up.
So it is again like targeting. It is not like they do everything and they will test. Is that?
In whole exome, they actually screen everything, but the clinical history is very important for them to like pick it up. Whatever history we give is very important. As you said, there is targeted gene. If we want to reduce the cost further, we can do a targeted gene analysis when we are very sure of the history and the diagnosis. When we have narrowed down, then we can do targeted gene analysis.
So what is your approach? Generally, you go for targeted genes more. How frequent do you ask for targeted genes, and how frequently you ask for a whole exome study?
Sir, like for example, in the episodic ataxia cases when I saw, so the history was quite clear. So we just did the episodic ataxia panel. But when it came to migraine and the other vertigo related disorders, the diagnosis completely to be sure of specific thing was not very clear. So in that time, I went for a whole exome. Depends on the case. Like if the family history is very clear and we're able to like narrow it down, then we can. I have gone for targeted gene. But otherwise, if I'm not very sure, maybe like 40% of the time when I was not very sure, I've gone for a whole exome just to not lose out on the diagnosis.
Okay, ma'am. Maybe you can, in the chat box, you can type the names of the labs that does us, so that it will be useful for all of us. Okay, ma'am. Thank you so much.
Yes, sir.
Thank you, ma'am. Thank you.
Thank you, sir.
So, yeah, I think Vishnu, you can allow all the participants to unmute themselves.
Sure, sir.
Nilotpal, Dr. Nilotpal.
Yes, sir.
Yes, sir. So Dr. Nilotpal and Dr. Anusha, both of them are there here. So questions from the participants we can take. I can see Dr. Isha is saying thank you. Dr. Anju saying very informative. Dr. Nikita, excellent workup. Dr. Surajit, excellent and fruitful presentations. Congratulations, thanks to Dr. Nilotpal. Dr. Neha, very nice presentation. Dr. Nilotpal, Dr. Rainbow Thung, very nice and helpful presentations. So thank you all for your appreciation. Dr. Sunny says thank you. But questions, please.
Excuse me, sir, I have a question.
Yes, ma'am.
Any blood tests to be done in the workup for pediatric vertigo? Any specific, other than for thyroid profile, if you're suspecting pendrit? But then I expect we'll see the goiter and we'll know to do it. But otherwise, wouldn't many children present with anemia?
Yes.
I mean, anemia, wouldn't that present with vertigo? Would actually it'll turn out to be anemia?
Yeah, from my point of view, are the two basic tests which I usually prescribe, and it's all referred cases. When patients are coming to a ENT, all the workups are usually done by the pediatrician or the pediatric neurologist. But if a direct patient comes to me, then a complete blood count along with vitamin B12, because in some kind of nutritional deficiency, vitamin B12, folic acid, all these things, there can be sometimes a nystagmus, sudden onset of congenital nystagmus, or kind of imbalance that can be there. Anemia usually presents with weakness and imbalance and fainting, pre-syncopal attacks which can be there. So the child is unable to tell you what actually is happening to him or her. So they always feel that it's a vertigo or it's a ear kind of thing. So those basic clinical, basic blood tests should always be done in a case of pediatric population, from my point of view.
Thank you, sir. Dr. Anusha, would you like to also answer the question?
Yeah, so like quite similar to whatever sir has told. So we need to, apart from the thyroid, we need to see for the nutritional causes like vitamin deficiencies, iron deficiency, and any of the like calcium and all electrolytes, the daily nutraceuticals, we need to evaluate for that. You need to also see for the general physical examination if there are any markers or other history pointing towards, because in every child you can't go on testing for everything. So you need to see the physical markers, history, and then you can evaluate. Apart from the nutritional evaluation and the thyroid, I don't think there are any specific blood tests to do for the vertigo evaluation.
Dr. Isha, do you yourself have any question, any blood test that you have been ordering?
No, just the CBC, just
Okay.
that, and
Okay.
stool OPC here.
Okay, ma'am. And I know you have a lot of experience with torticollis.
Not so much any longer.
Okay, ma'am.
There are two cases which I remember
Okay, ma'am.
recently. So last week I had a child. So the history, even now that I'm not sure about diagnosis. So I was thinking everything happened after fever. It was like a migrainous episode, spontaneous episode with some headache. But the history which he gave was he's around 10 years. He tells that he feels that someone is talking. So I was asking, is it like you feel someone is talking to him? Like, I thought it's psychiatric. Then he told he can he can feel that someone is talking, but he cannot follow what the conversation is. So finally, the neurologist had taken an EEG. He had mentioned some non-specific changes, but he's under follow-up. Don't know. And one other case I remember is one patient following fever, and it was diagnosed with transverse myelitis with unsteadiness, sudden episode of unsteadiness.
Dr. Anusha, I think you would want to throw some your thoughts on the first patient.
Yeah. The first patient, I think, is having some behavioral disturbances, like hearing someone talk with not exactly very clear. Such kind of a semiology you can see in temporal epilepsy specifically, I would say. Parieto-temporal, predominantly temporal more than parietal. So the seizures or epilepsy seen when in temporal regions are not very classical like the typical GTCS. There can just have like a behavioral change, hearing something and sudden aggression. So that is noted in temporal. So I think maybe that could have been there. You need to see the EEG for finer, even though like there are occasional discharges, they will respond, and maybe an imaging would help post your EEG.
One more thing for the first case, which I want to add, is there is a specific entity called a conversion disorder, which I have found in few of the female usually patients. It can happen in male childs also, where they tell that suddenly there is something going to, someone is trying to throw him from his home or from his bed or her bed. So when you do a psychomotric evaluation, which is usually done by a thorough bunch of tests, psychometric tests by a psychological counseling, then you can find out there's a huge psychological overlay. So there can be a vestibular epilepsy or focal seizures, but always this kind of offbeat or off-track patients which are telling where you are feeling that nothing keeps into your protocol, that this comes under a specific disease, I would always advised to go for a psychometric evaluation. Ask the parents, take up family history, take a school socioeconomic, how he is behaving in the school. The child sometimes, if it's a strict childhood, if they are not, there is a parents are having some problems in a family or their marriage. So all these factors are very important when you examine a child with balance disorders.
True, sir. Yeah.
I see Dr. Sandeep Sharma there. Dr. Sandeep Sharma, he sees patients from newborn to the oldest patient. Dr. Sandeep Sharma?
Sandeep sir, namaskar.
I don't know, he was here. Dr. Ramesh Rohiwal, sir? but I don't know. Both of them are okay. Sir, as sir is saying hi, hello. I think he's not having access to mic. Prakash Nachinolkar, sir, thank you for joining. How is Goa? Okay, we can't hear you. Maybe lot of dizzy drugs overflowing there. Yes, sir. Anybody has more questions, please ask. Okay, we can't hear you, sir, Prakash, sir, but we can see your thumbs up. Thank you. Yeah. Okay. Thank you. Okay.
Dr. Srinivas, I joined little late. I just wanted to know what is the test battery you use for, you advise for pediatric age group patients.
I think Dr. Nilotpal covered in detail, sir. What I will do is I'll request the presentation from him, and if it's okay,
Sure,
we'll share it with all the participants. Dr.
So
Nilotpal,
nice.
can we share this
Yes,
presentation with all the
definitely.
participants?
It will be my pleasure to share with.
Then we will. Okay. I think with Dr. Anusha also we'll request the presentation.
Sure,
In nutshell, sir, also in nutshell, the three important things which I do, and I have found these are advantages. One is to ocular checkup, eye examination in a child. Always send for a ophthalmological examination to your colleague, mentioning three things: refractive errors, divergent anomalies, and to rule out any strabismus. This is the important first of all ocular examinations. If you are suspecting any central cause, repeated vomiting, torticollis, headaches, or any abnormal gait, if you are suspecting any central disorder, go for an MRI with a specific mentioning of that posterior brainstem cerebellar lesion. And thirdly, in case of audiological evaluation, you can do it for if there is a severe deafness or something is there, then there you can go for audiometry and BERA, and a VOG, video nystagmography. That is very important. If the child is around 6-7 years of age, a mild cooperative, you can have toys or chocolates in the clinic and insist the child to go for this. Then these 4 tests are very important if you are going for a test battery approach in a pediatric vertigo, what I follow in my practice.
Thank you very much. Thank you very much.
Thank you. So for the presentations, what I suggest is you can all WhatsApp to Vishnu. Vishnu will share his number here in the chat box. So just send a WhatsApp to Vishnu. So post he receives the presentations from the speakers, he will share with all of you. That will be the easiest and most convenient. Okay, Dr. Akila, I think you can also just send one WhatsApp to Vishnu. Vishnu will be sharing his number here. Okay.
Yeah, sharing, sir.
Yeah. Just WhatsApp him, and then he will get in touch with all of you, and he will send. So fine, if there are no more questions, I want to thank, I'll just wait for Vishnu to put up his number. Okay. And Dr. Anusha has actually again shared her, the names of the protocols again in the chat box there. I mean, names of the labs where she gets things done and the kind of test that she gets it from. Vishnu has put up his phone number in the chat box. I'll just repeat that: 8951255528. Once again, 89512895. Vishnu, that is not full numbers, man. All 10 numbers are not there. Okay. 895125558. Okay. 895125528. That is Vishnu's number. You can just send a WhatsApp hi to Vishnu, and Vishnu will share with everybody. Okay. So thank you, because we'll lose access to these chats once we close this. So that is why please remember this number. Okay. So with that, I again want to thank both Dr. Anusha and Dr. Nilotpal. Okay, thank you so much. Okay, you brought in a lot of insights and experience. We would want to keep wanting you to keep coming to all the grand rounds. Okay.
Thank you, sir.
Some as a panelist, in some just like a panel. Maybe you can come over. We can always have some discussion. Okay, even if you are not exactly as a panelist also. So thank you all. Thank you so much to Dr. Nilotpal again, Dr. Anusha, and for everyone who has joined us today evening. So this grand rounds will keep continuing every last Friday, 8:30, last Friday of every month, 8:30. So we'll keep bringing in some new case discussion or some new topic or something like that. It'll keep happening. So please keep joining us. Thank you, Dr. Shalam. Okay, so thank you, sir.
Thank you, sir.
Thank you all. Thank you. Thank you.
Thank you.
Thank you. Thank you, sir.
Thank you all.
Thank you.
Thank you all. Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Surajit writes excellent cases, Dr. Anusha. Thank you so much.
Thank you, sir.
How do we know about the next session is one question. Okay, Dr. Akila, just send one WhatsApp to Vishnu. He will add your name into the list of people to whom we broadcast the message. So next time, whenever there is the session, we will broadcast it. But about the joining details, everything. Thank you all.
Thank
Okay,
you, sir.
Vishnu, I think
Thank
you
you,
can end
everyone.
the- Thank you.